Another 2 minutes, we'll start letting them in. There are already around 30 people in the waiting room.
Okay.
Okay. We are actually, the registrations are over 200. Let's see how many turn up for the event.
All right. Hello, ladies and gentlemen. Hope you're all good. This is Wali from IQE Academy, and I am basically the student service representative over here. And we are welcoming you to a very historic occasion over here because for the very first time ever, should I say, we are hosting a webinar along with Transform Training, which is related to first aid and in the earlier sector for educators as well. And we have a very renowned individual with us over here, Dr. Lindsay Lavery. We will give a brief introduction about him, but we have around at least 9 minutes more remaining. So keep your seats warm. We have 9 more minutes. If you've got anything to do, get yourself a cup of water, just relax, wait for 9 more minutes, and then we'll get this webinar started. So thank you once again for joining in, and we'll see you in 9 minutes.
Oh.
All right, so we're starting in another minute, or just one more minute, and then we're good to go. All right, so hi everyone. Thank you for joining once again for this groundbreaking webinar that we're having, because for the very first time, we are having a webinar which is related to first aid for earlier practitioners. Again, I'm thanking you all. There are more people coming in and we'll be welcoming them as well. And it'll be Dr. William Lindsay Lavery, who will be basically responsible for all of us over here in transmitting all that knowledge that he has, that diverse knowledge, that vast knowledge that he has over the years. We'll give you a brief introduction about him as well and what you can expect in this webinar. So he is coming here on behalf of Transform Trading that has a clear mission, which is to create a safer workplace. And they do believe that in order to basically progress as an organization, in order to be successful, you do need to have a safe environment. And whatever he's going to tell you today, this is something which is going to have a deep impact on you, which will definitely have a major role to play in your career as an educator as well, whenever in the long term as well as in the short term. Now talking about the man of the moment, Dr. William Lindsay, ladies and gentlemen, he basically has an experience of more than 30 years, so truckloads of experience over here. Apart from that, he has been consulting with major corporations, advising for safety policies, as well as and as well as for high stake moments, overseeing safety frameworks, updating response legislation, and developing health and safety courses. He's also advised on national safety protocols, ensuring that the workplaces have safe, reliable systems in place. And additionally, apart from that, he's also played a crucial role in developing courses and offerings such as the National Examination Board in Occupational Safety and Health, as well as the Institution of Occupational Safety and Health. So as I mentioned, Dr. William Lindsay Lavery is going to basically have the floor for the next few hours. He will be taking care of you all, whatever doubts, whatever queries you have, just listen to him carefully. You will get a lot of knowledge tonight. And once again, we welcome you all. So Dr. William, the floor is yours. I'm taking a back seat. You're in charge now.
Thank you ever so much for that kind and gracious welcome. So first of all, I'd like to say good evening, everybody, and thank you for allowing me into your homes or your workplaces this evening to give a bit of discussion around fundamentals of first aid, especially in the academic environment. As I've already been introduced, I won't say a great deal other than I work alongside and with Transform. And I've spent over 30 years working in emergency and crisis management in various elements, medical emergencies, disaster control, obviously more recently within the UAE, advising and working with the government on the COVID campaigns and the strategies that were adopted there and then. But this evening, we're going to focus mainly on the most important people in your lives outside of your family, which is the children that are in your care on a daily basis. So tonight we're going to have a look at some basic fundamentals of first aid. We're not going to go through all the elements of first aid. I will be discussing about cuts and bruises and bumps and scrapes. We will touch on them gently, but what we will focus on mainly is two key areas. And those two key areas will look at things where time critical intervention is essential for the well-being and the recovery of that child in your care. Now, just before we start, what I want to do is I just want to very, very quickly let you know that we as Transform, or as already introduced, are an online learning portal. We focus on health and safety training, although we do offer bespoke training if required by various organizations. And we do e-learning, we do virtual classroom, and in certain cases where it is mandated, we will do face-to-face training. First aid example, what we're doing tonight is not a certified course, I must stress that. It is a flavor of things for consideration, but it's something that we could then deliver in your workplace as a face-to-face program certified. We specialize, I said, as in first aid, in health and safety, which first aid is an element. And we have a head office in Dubai. We have a subsidiary office in the UK where I'm based. And then we have personnel working in both Western Europe, the Middle East, and also Central and Southeast Asia. So we've got quite a bit of spread in what we're trying to achieve here. So just before I go into the critical interventions that you should be considering in your environment, I'm just going to touch very quickly on a bit of legislation which is relevant to the Middle East, or well, to the UAE in particular. And that is in terms of what is the medical support requirements as a minimum that Dubai, Abu Dhabi, Sharjah require an education establishment to have. And what they say is that for every 1,000 children in education, there has to be one full-time nurse in a school and one part-time doctor. That's mandated. If you've got less than 1,000, you still need to have the full-time nurse, and there must be a link to a doctor, although not part-time, but so that can be consulted with. And then if you go to between 1,000 to 2,000 children, it should be 2 full-time nurses and a full-time doctor. Now, they're big schools. They are big schools. But technically, there should be at least a minimum per 1,000 of 1 nurse per 1,000 children in the school, with a link to the doctor if required. Now, that sounds pretty good, and it actually is pretty good. It's better than it is actually where I'm from in the UK, where we don't have that system of a qualified nurse within the establishment. The difference being is in the UK and in other parts of the Western world, the expectation is that there are a cohort of individual teachers who are first aid trained in the basics of first aid and the basics of life support. So what I want to touch upon this evening is, although we have the safety net of our nurse and hopefully our doctor within your educational establishments, there may be a delay from you being present in a major event, medical event, I should say, and alerting the nurse or the doctor to attend at your location with that child. Now, as I said a bit earlier, bumps and scrapes and cuts and bruises, generally, they're not time critical. You know, we can put a compress on a bruise. We can clean a scrape. We can put pressure on a small cut or a sticking plaster. But when we get to the more traumatic events, choking, a loss of consciousness, a bone breakage to a degree, these things become more time critical. And the doctor could be 1, 2, 3 minutes away. So we need to make sure that we, as child practitioner carers, are in a position to administer that initial care, which could potentially prove vital to the safety of that child, the well-being of that child, and the recovery of that child moving forward. So today's goal is to look at 2 key elements: choking, which actually you'll be surprised how often it occurs in schools, and also an unconscious, unbreathing child. Again, thankfully, it's a rare event, but it does occur annually, globally. And it could well be that the next time it occurs, it could be you as the carer for that child who has to take the actions necessary. So just before we do that, I want to just touch on a few facts and figures. They're not overly wow. However, they do give a very good indication of injuries in schools. Now, this study that I'm showing you now, this first table, this was actually a study undertaken by a lady called Dr. Albiel back in 2015-16 over a full academic year. And her colleagues studied 10 different private schools in Dubai. And what they did is, over the year, they recorded all of the accidents that occurred in them 10 schools. And then in 2016-17, they analysed the data and they published a paper on the evidence that they found. And I'm going to just highlight 2 or 3 slides here, just to give you an understanding of the kind of things that you probably see on a daily basis, but they've now been analysed and there's been data shown to prove this is what goes on in schools. This is what you as a teacher could be faced with. So the first thing I want to show to you is the number of incidents that are occurring in a year. So what happened was, we identified in the 10 schools, if you look at the very last row, there was 13,336 pupils looked at over an academic year. And of them 13,336 pupils, there was a total of nearly 4,000 injuries. So it's almost 30% of the population in some way, shape or form suffers an injury while in school during the academic year. Slightly higher up in the table, you will see that predominantly it's boys that have the problems. Of course it is. Boys do silly things more so than girls. What we would say is girls are a bit more sensible, they're a bit more cautious. Boys have a bit more bravado about them, especially as they get slightly older and they start to go through puberty and the hormones kick in. So we tend to find that the ratio of injuries, boys to girls, is around 3-to-1. And then looking slightly higher up, we tend to find that the top tier of injuries occurs in the 14, 15-year-old age range. And that is, again, predominantly in the male population. And again, a lot of it is hormonally driven because of these new hormones swirling around their bodies. They tend to take more risks. They tend to show off a lot more. I'm sure you see this in your schools from time to time. And as a result of these chances and dares and being a little bit more outside of their comfort zone, they are more susceptible to injuries. Thankfully, for the most part, injuries are minor. But again, in the next slide, sorry, not the next slide, the slide after, we look at the severity of injury. But in the next slide, we'll look a bit more at the types of injuries which are occurring over an academic year in schools across Dubai. And we can extrapolate this to schools across the world, if I'm brutally honest. So if we look at the distribution of injuries among school children, and again, this is from the same study from 2015-16, we understand that nearly all of the injuries, or the majority, are from falls. So when we have a fall, we tend to get a scrape, we tend to get a bump, we tend to get a bruise. These are very minor injuries. The second highest incidence is cuts, and then that is followed by other. And other could be anything from scratches, paper cuts, and the likes. It's just a mishmash of different things. It's not anything major. It could be a spelt or a splinter in a finger. It could be, something in their eye. And then we move down the list. We got animal insect bites, but the two I want to draw you to the most are the two smallest ones. Right at the bottom left-hand edge of the pie chart at around 7 o'clock, there's a 1% and a 0.5%. The 0.5% is actually accidental poisonings, drinking things that they shouldn't be drinking. Okay? And we're going to come to that very shortly because that will play a close link into the 1%, which is accidental choking. Now, before we move on to the third slide in this little overview of statistics, which will be the last slide I'll tell you, what I want to make you aware of, if you think the schools here, there was 10 schools, there was 13,500 pupils, so there was on average around 1,000 pupils per school observed. 1% would mean that 10 children in that school in an academic year suffered accidental choking. 10 children. And 5 children suffered some form of accidental poisoning, either by ingesting something or being in the presence of a toxic substance and they're ingesting it through smell, through vapors. But overall, 15 children in 1,000 each year in Dubai schools are potentially going to be exposed to some kind of choking or poisoning incident, which is food for thought. So if your school is a big school, if you're 1,000 kids in your school, 10 of them in a year may well suffer some form of choking, 5 may well suffer some form of poisoning. And obviously if it's a smaller school, it still occurs, but the frequency would be slightly less. So the last slide is just to look at severity. And we looked at, again, the 3 age ranges, 12 to 13, 14 to 15, 16 to 17. and we looked at them as mild injury, moderate, severe. Severe is hospitalisation. Moderate might be just to deal with the nurse and the in-school clinic with the doctor. And mild might just be a clean of the wound and a dressing. Or if it's a bump on their head, maybe some kind of anti-inflammatory or some kind of cream, and that's the end of it. And I'm not going to focus too much on the mild and the moderate. I'll look at a bit more at the severe, because the severe is where we begin to require time-critical interventions. And I'm not going to go into great depth on this because I think it's quite self-explanatory. But when we look at the severe, thankfully, the frequency of severe injuries is an awful lot less than the other ones predominantly. Not always the case. Again, when we track across our 14 to 15-year-olds, in the year in question, there was actually 31 severe accidents with injury, as opposed to 16 moderate. And again, it's that hormonal band where these things are occurring. Now, this could include things like days, people being dared to do something a bit dangerous, which could actually then lead to an accident and an injury. It could also be due to sort of scuffles between predominantly, hormonal fueled boys trying to be the best. But what we tend to find overall is, as we track from mild to moderate to severe, normally the frequency gets less. But the problem is they still occur, and we must be prepared to deal with them. And again, the last thing is looking at the male and the female. The ratio of male injuries to female injuries is nearly treble. So if you work in an all-boys school, you better be prepared. If you work in an all-female school or an all-girls school, you can not relax fully, but you've got it a bit easier. So what we want to look at now is, what is the role of the first aider? Now, I'm not talking here nurses and doctors. Their roles is very, very descriptive in what they do. But you as a teacher or a teaching assistant should be able to provide some kind of immediate care to a child if they, in some way, shape or form, have any kind of injury, no matter how mild or how severe it may well be, until the professional help does arrive. So the 3 Ps is what we call it. We preserve, prevent, promote. So the first thing is if a person is injured, we want to make sure that we can look after them. We preserve their life. So what we want to mean by that is we don't want to neglect them to the point where that life is lost. We want to preserve lives, keep them safe, keep them healthy. The second thing, the sooner we intervene to support and care for them and provide the necessary medical interventions, we kind of begin to lock in the amount of damage occurred, and we prevent further deterioration. So the sooner we can lock in our care and stabilize the casualty, the less severe the injury can become, the less likely that child will be to deteriorate, and therefore long-term, after they have recovered, they are less likely to suffer any long-term problems associated with that injury. So preventing deterioration is what we call it. And then obviously the last one ties in with the second one. If we can prevent deterioration, what that then means is we promote recovery. So the quicker we can get from deterioration to promoting recovery, the quicker they will recover, and also with less long-lasting problems associated with that illness or that traumatic event that occurred. So the 3 Ps: preserve, prevent, promote. So now what we're going to do is we're going to look at, as I mentioned earlier, 2 various aspects. The first one is choking. And we will look at choking because you'd be surprised, as I said already, I was quite surprised to think that in every 1,000 children each year, at least 10 of them are going to suffer some form of choking. Although when I look back a bit and I think about the age range in children, even though we focus here on 12 to 17, the younger a child is, the higher the prevalence of choking becomes, especially when we go to the 3 to 6-year-old, where they are constantly putting things in their mouths. The choking prevalence actually goes double in that age group. but I haven't got all the stats to show you on that one. But trust me, falls, cuts, bruises, bumps, and choking are higher in smaller children than they are in sort of that teenage band frame. So I'm sure we're all aware of choking, and I'm sure everybody who's attending here this evening at some point has been in the presence or themselves has been choking. I know I have, and it's not a pleasant experience. And most of the times it's because we're eating and we're talking at the same time, and a bit of food goes down the wrong way, and all of a sudden we have this horrible feeling in our throat. It's not a major panic at this point, but it's a horrible feeling. And we start to cough and splutter, and we don't want to talk. We want to cough. We want to get that obstruction out. We want to get back to normal breathing. Okay. Now, in choking, we would call it a partial choke. And what that means is there's an obstruction in the trachea, which is the pipe going from the mouth down to the lungs, which is obstructing to a degree the air that can pass up and down and through our respiratory area. Majority of obstructions clear fairly quickly. We cough for a minute, our eyes water, and then we spit it out. We expectorate the problem, and then we can carry on as normal after a few minutes of setting ourselves down. However, choking can also cause quite a large breathing difficulty. If it is a large object and it pretty much blocks the entire airway, this becomes what's called as a full choke. And at that point, there is hardly any air passing up and down. And that's when we get into the more dangerous situation where, again, as I keep mentioning again, time-critical intervention from your perspective is vital to that child's well-being. Now, just before I go further into partial and full choking, at the bottom of the slide, you can see there's quite a few examples. You know, foreign bodies such as food. I'll go further. I'll say Lego. I will say paper. I will say, especially from young girls with long hair gets caught in the back of the throat sometimes. These are quite often the main events around school, along with allergic reactions. And in there, I would also include insects. Because quite often, if you get a bee sting, or you may drink something, or you smell something that might have an irritation on your throat, you can have a form of anaphylaxis, whereby the lining of the trachea starts to swell up. So it's not a blockage by an object, it's actually the airway gets tighter and tighter and tighter and constricts itself. And that's anaphylactic shock treatment, where the airway is occluded, not because of an object, but because of an allergic reaction. And again, that would normally be dealt with EpiPens to relax that airway. Asthma, again, asthma is a one where we can start to occlude the airway down. Blood and vomit is normally around a major trauma. For children, in any case, it's normally around a major trauma. It's not normally all of a sudden so that it just occurs. A nosebleed occasionally, but normally it's in a major trauma where the person will be on the side rather than standing straight. And as they're on the side, the vomit or the blood can just gather in the throat, kind of congeal and obstruct an airway. It's a very, very rare event. Predominantly in our sphere, it's going to be more around the foreign bodies and potentially an allergic reaction. So I'm going to ask a question. I'm not asking for answers, but the question I'm asking is, so what's a partially blocked airway? Well, and how does it differ from a fully blocked airway? Well, I've already indicated that a partially blocked airway is where something inside that you've ingested sits in the airway and it doesn't fully block your trachea, but it does severely limit the amount of free space around it to allow air to move from the lungs to the mouth and from the mouth to the lungs. Now, obviously, we breathe a certain volume of air in each breath that we take. And the reason why we do that, we need that volume of air to actually perfuse the blood and then support and the energy and nutrition around our organs and our brain. So if for some reason that volume of air is reduced over a period of time, the brain gets less perfusion, it gets groggy. The organs get less energy because there's less oxygenated blood going to the organs and the muscles, so they become weak as well. So although a partial blocked airway might not sound too urgent, and in most cases it isn't, if a partial blocked airway does persist, it will lead to more dangerous effects for that individual further down the line. So you must bear that in mind and relay that element later on when we go to full choking. But for the most part, a partially blocked airway means that the person has difficulty speaking or coughing. They can still cough, their talking will be a bit wheezy because they can't breathe very, very well. And the breathing will be a bit noisy or a bit rattly because the ears have to try and buffer past this blockage, and it will come out a bit wispy like that as the child is actually also holding their throat. They'll be gasping for air, and we'll all gasp for air. Why will we gasp for air? Well, as I've already said, every breath that we normally take in is a set volume of air, 1 to 2 litres per breath. When the airway is obstructed, that volume per breath is massively reduced. So the brain thinks, I need to breathe more rapidly to get more volume of air into my lungs to satisfy the needs of the brain and the lungs and the heart and the liver and the muscles, etc., etc. So we begin to increase the rate of breathing, but it is very, very rattly. And the breaths are very, very shallow because we can't get all the air out the lungs for deep breath. It's tiny little pants that tend to come out. And then the universal sign I've already mentioned, we clutch our throats. Clutching the throat is of absolutely no help at all. It's a comfort mechanism to help us. Although if we hold the throat in, we actually we end up constricting it more. So we want to try and keep away from that. And then obviously the last thing is there's the panic and the distress. Now, in a minor choke, we've all been there. You're slightly discomforted by it, but you know it's going to pass. As these things prolong or progress and the object doesn't move, panic does set in further, regardless if you're a child or an adult, and they will become visibly distressed. You'll see the mouth begin to open, to gape, the nostrils will start to flare, the eyes will start to come wider. It's a sense of panic in that individual. But we have to remember, this is a partially blocked airway, so in most cases, that individual will be able to successfully remove that object themselves through their coughing process at this point in time. I won't say any more on partially blocked airway just yet. We'll now compare the partially blocked to the fully blocked. And then once we've done that compare contrast, we'll move on to what you could do in those first moments to assist that child who is suffering some form of blockage. So when we go to a fully blocked airway, as I said previously, we have wheezy coughing, wheezy breathing, because we still have some movement of air from the lungs through the mouth and vice versa. When we go to a complete blocked airway, it's like a cork stoplight in the top of a bottle. There's nothing getting in and there's nothing getting out. So this time, the person can't speak, because in order to speak, you must travel air through your voice box. We can't do that now because it's been closed off. When we cough, we can do that when it's partially blocked. When it's fully blocked, the cough it's silent. The cough's got nothing pressuring it to actually create that movement of air and the cough sound. So we get a silent, ineffective cough. We still try to cough because it's a reflex, but the cough is dormant. It can't provide any back pressure to help the lungs force the object up and out of your mouth. So although we do it, it's called a silent cough. We still clutch at the throat, but we clutch quite vigorously this time. You'll start to find the veins on the back of the hands will stand out because you are really grasping at your throat, trying to make some kind of effort to push whatever is in you, stopping you from breathing, out of your body. As the choking duration progresses from seconds to maybe 30 seconds to the minute, you will start to see possibly the lips and around the base of the eye, on the side of the eyes, will start to change colour. They'll go from sort of a rosy glow and the pinkishness of the lips, they'll start to get a bluey tone or a purpley tone to them. We call this cyanosis. What is that? Well, it's quite simply is the body now has a lot of blood in its system, but no longer is that blood nice and pinky red and full of oxygen. The oxygen is being used by the body, but it can't escape and it can't be reoxygenated through the lungs. So the blood begins to change colour because of the carbon dioxide that's sat in the system. And we get this bluey tone to the lips. We call it cyanosis. And this is very indicative of the completely blocked airway being at the point where that individual is now oxygen deprived, and therefore it is now getting very, very serious and dangerous to them, because that indicator also tells me that that person is not being able to oxygenate the brain, so the brain is now being oxygen starved as well as the rest of the body. And this becomes very, very dangerous to the individual, to their general health, and also to their long-time recovery. The panic and the stress, what we saw in partial is ramped up under a full choking condition. The eyes will be very, very wide. The mouth will be gaping. The nostrils are flaring. The individual will not be running around. They'll be standing pretty much stock still, holding their throat, bending forward. Their skin will start to ashen and they will start to get a panic, waxy sweat on them. These are all indicators that we are at a point now where we are close to that person losing consciousness through suffocation, through lack of oxygen. So at this point, if we don't help that individual to remove that blockage, that casualty most likely will very quickly lose all consciousness, become unresponsive, and at that point, the clock is ticking faster, because at this point now, without intervention, we are potentially going to lose that individual's life. So this is where I come back to, these are the 1-2 minutes where you as a teacher or a teaching assistant or as a parent, it doesn't make any difference, can intervene to protect that person's life and their recovery protocols while we wait for medical help, which could be 1 minute away, 2 minutes away, could be 5 minutes away. What I will tell you, every minute will feel like an hour. It really, really will. But by keeping yourself calm, thinking logically, there are things we can do to hopefully prevent this, or if we do get at the unconscious situation, things we can do there to help retain and sustain that life until that expert help does arrive. So what do we do if we find a person really, really choking? Well, the first thing we're going to try and do is, if it's a partial block, we're going to encourage them and reassure them. So we'll put a hand on them or on their back, rub their back, go on, cough, keep coughing, big cough. Try and get it up, get it out. Bend them forward slightly because gravity will help them to expel it, and just reassure them. Brother, all the time you're monitoring them. You're monitoring them for the sound of the coughing, for the talking, for the bluing of the lips and around the eyes, or the waxiness, the flaring of the nostrils, because all these will indicate that if these are starting to occur, we're getting closer to the unconscious phase. And at the point where we then think, at this point, I need to assist them, because although it's a choking casualty that might be partially blocked, we're getting to the symptoms now of fully blocked. And we need to do something now to try and alleviate that blockage. Above all else, you must stay calm. If you can stay calm and reassuring to them, although you may not think it, it does help that individual to know that you are there and you're there for them and you're going to help them. Okay? So if we get to the point where that individual cannot expel the blockage, and we've done all the reassurance, the first thing we want to do is, as we're monitoring them and we're thinking, this is not coming out, this blockage is not going to come out by itself, first thing to do, phone 998. If it's in the UK, it'll be 999. If it's in the US, it'll be 911. So please understand what is the emergency service number for your area. If there's somebody else with you, let them make the phone call and let them deal with that communication with the emergency services as to what's required and what the scenario is. Your job then is to assist that individual to try and physically remove that obstruction from the airway. So how do we do this? Well, I'm going to show a video very shortly, just a short video which will demonstrate these techniques. But first of all, I'll just talk you through it. First of all, what we try to do is we stand just behind the casualty. We put one hand on their chest, and then we stand behind them, and we will bend them forward slightly. Again, it just helps them to expel once we get the movement going. And then with the palm flat of our hand, between the shoulder blades, we will do 5 fairly hard back blows. And we aim between the shoulder blades. The idea being is we are pushing the back of the diaphragm cage. We're doing a slight compression on the diaphragm. And 2 things. First of all, the movement might just dislodge the object by that physical slap on the back. The second thing is there's a slight push in the diaphragm cavity, which might just give a nice pop of oxygen or air trapped inside the lungs to pop the object out of the mouth. It might work, it might not, but the first thing we do the 5 back slaps or the back blows. If they are unsuccessful, we would then try and do an abdominal thrust. It's also known as the Heimlich maneuver. I'm sure you've all seen it before, either in a film or if you've done a first aid course, or you may have seen it actually for real. I don't know. So in the abdominal thrust, we maintain the position behind the casualty. And what we'll do is, again, we'll bend them forward. And then with one hand, we make a fist. Now, when we make a fist, we put the thumb inside the palm of our hand. We curl the 4 fingers over the top. And we put this fist just above the navel, so between the navel and the bottom of the sternum. And then with the other hand, we clasp the hand on top. So we have our hands around the midriff of the choking casualty. And then what we do is we do an upward thrust. It's actually a pull, not a thrust, but it's an upward thrust, it's called. And what we do is we take our hands in towards the center of the belly, and at the same time up, as if we're going up into the rib cage. And we'll do 5 sharp thrusts. And the idea there is there's a lot of air in the main torso. And by us doing an inward thrust and an upward thrust at the same time, we're moving all that air that's trapped in this area below the obstruction. We're putting this air under pressure up through the lungs, through the trachea, to the base of the obstruction, and we're creating a high pressure. And hopefully that pressure will be sufficient to dislodge the object and let that object expectorate from the person's mouth. So 5 back thrusts, back slaps, then we'll do 5 abdominal thrusts. And hopefully within those 10 movements, that object will be removed and the airway will be restored. Occasionally, sadly, that doesn't work, in which case what we would then do, we would repeat the cycle. 5 back slaps, 5 abdominal thrusts, 5 back slaps, 5 abdominal thrusts. And we keep repeating and repeating until either the object removes, the casualty becomes unconscious, or medical help arrives and they will then take over the process. That's how it works. Now, just before I show the video, I want to just give a couple of little caveats to this. There's only 2 caveats, but the first one is infants. Infants are deemed as any child under or around the age of 1 or lower. Now, obviously, we don't do back slaps for young children. we just do a couple of fingers, and we never ever do abdominal thrusts with an infant. What we would do, we would lie the child, because the only 1 year old is quite small, in our arm or flat-ish on the ground, ideally with the head pointing slightly down. And we will use 2 fingers, and we will take them 2 fingers, and again, the same location above the belly button or the navel, between the navel and the sternum, and quite gently, we will just push with 2 fingers in and up into the rib, into the diaphragm. Any heavier than that, we risk rupturing the diaphragm. We can actually deflate the lungs, or we can crush the lungs, or we can crush the ribs. So we use 2 fingers on a small child. Above a small child, we would use 1 hand for maybe it's a 1 year old or a 9 year old, but if they're a big child, we would still use the 2 hands. So remember, an infant, 2 fingers, and it's a push on that chest. For a 1 year old, around 9 year old, you gauge it. Again, it's stand behind, but with just 1 hand going in and up. Anything above that, sort of 10, 12 and above to an adult, or if it's a big child, you can then use the 2 hands. And the same thing with pregnant women. If we have a pregnant woman, again, we don't do abdominal thrusts. Again, we would go to the front, lie them, get them to one side, and again, we would just use the fist, and we would push the fist in above the pregnancy bump. So it's not at the navel, it's going to be above the pregnancy bump, into the base of where the pregnancy bump and the rib cage come together. You're going to push in and up into there, mainly because any abdominal thrust on a pregnant woman could potentially have an impact on the unborn child. Okay, so I hope that makes sense. So what I'll do now is I'm going to show you 2 quick videos. One just to understand and visualize how the back slap works, and then one how the abdominal thrust works.
If the child is conscious but struggling to breathe or has stopped breathing altogether, begin giving them back blows. They're more effective if the child is positioned with their head down so that gravity can do most of the work. Lie them across your lap if possible, or if they're too big for that, support them as they lean forward with their head down. Use the heel of your hand to give 5 sharp blows between their shoulder blades. Then move on to abdominal thrusts.
Okay, so that was the back blows. Very simplistic, very straightforward, very effective in the majority of cases. And here is the abdominal thrust, or the Heimlich maneuver.
Stand or kneel behind the child. Place your arms under their arms and around their body. Make a fist with 1 hand and place it just below their rib cage, above their belly button. Grasp your fist with your other hand and pull sharply in and up. Do this 5 times. If a blockage remains and there are other people nearby, get them to call an ambulance. Then repeat the 5 back blows, followed by 5 abdominal thrusts until the blockage is cleared, the paramedics show up, or the child loses consciousness. Even if you're successful, the child should still be checked out by paramedics to make sure that the blockage has completely gone and there are no injuries.
So I think we've kind of covered choking now. So we understand what the types of choking are. We have partial choking and have full choking. We understand now the indicators of what you expect in partial choking and how that can progress to full choking, with the changing from the wheezy cough and the raspy voice through to the silent cough and the no speaking and the cyanosis, the blowing, the weakness in the body. And eventually, if we don't restore the airway, because there's not enough oxygen getting to the muscles and the organs and the brain, that child will then move into an unconscious state and they will collapse. And again, like the video says at the end, regardless if we get that object out of that individual, they should still be followed up with a medical checkup, just in case there's any airway damage that could have occurred by the blockage. Or also it may well be that there may still be partial blockages in the airway that might need to be intervened with at the clinic. So airways, we now understand why you as a child carer and an education provider have to be aware of these things. Not that you ever want it to occur, but if they do occur, that your quick reactions in those first critical seconds is going to be vital to that child's safety and longevity. Now, linked to full choking and an unconscious child, we can sometimes find that we'll come across an individual who is just lying on the floor and there's no movement, there's nothing at all. Now, it might follow on from choking, and it can do. It's rare, but it can do. Or it could well be that it's a whole different scenario where you turn a corner and there's a child unconscious. And as I said earlier in the statistics, it's rare, but it does occur. 1 to 2 per thousand every year in Dubai alone. So it is rare, but it could be that the next one that occurs could be when you turn that school corridor and you need to act fast before medical help can come and support you. So
I need to get the certificate.
Hi everyone, there seems to be an issue. There seems to be a glitch with Dr. Lindsay. We are trying to reconnect things, so just hold on. We'll bring him back. Just give us some time. Thank you.
बाकी उत्पादन इतना बड़ा सिस्टम दे दिया सब बर्दाश्त की तो ऊपर चैलेंज है ये मुझे जगह गया
my apologies there. I do apologise. We had a momentary power cut where I am, which has locked me out. I've just got myself back in. Can anybody give me a thumbs up they can hear me?
Yeah.
Yeah, we can hear you loud and clear.
Perfect.
Yes, sir.
Yeah,
Can
we
you
can.
please
Yes, we can hear you.
Yes, sir.
Thank you now. Can IQE, can you please give me permission to reshare again? Thank you.
I'll just make you the host. Give me a second.
Okay, thank you. I apologise for this, everybody. I wasn't expecting a power cut.
It's done. You can check now.
Okay, thank you. Okay, sorry, I do apologize, everybody. So, as I was just saying, is what can happen is we can get in a position where either because of the choking or for a totally unrelated event, we could come across an individual who's lying in a corridor, in a classroom, or on a playground, who was just unresponsive, lying there. We don't know what the reason is, but it may well be that they are having trouble breathing or their heart may have stopped working. We don't know. So as we're aware, we call this cardiopulmonary resuscitation.
Yeah.
Now, as I said at the beginning, what I'm showing everybody now is an overview of the course. This isn't a course which at the end of it, you can say that you've been trained. I must make that very, very clear. I'm giving you a flavour of what we do. So when we get to an unconscious or an unresponsive child or a person, how do we know that there's something wrong with them? Well, we don't initially. But what we have to do is we've got to make some decisions and some judgments based on what's in front of us. Now, the first thing is, before we go through these 4 blocks in front of us, look around you. Look around you. If that person is lying on the floor and there's a pool of liquid, it may well be that that liquid is the reason why that person is lying on the floor. They may have slipped on it, bumped their head, knocked themselves out. That's one option. Another option is it could be some kind of chemical. And if it's a chemical, it could be that the vapors from that chemical have asphyxiated that child, which has knocked them unconscious. We don't know. So there could be a hazard in the area. It could be that there is a light fitting hanging down and a bare wire. The child, therefore, could have been electrocuted. Now, these are ifs, but we look at the environment first to identify, is there anything that we can identify in the area that could be the cause for this situation? Secondly, if there is a hazard in the area, you can't work on that person in that hazardous environment. You've got to move them out of there into a place where it is safe for you to provide first aid medical care to that individual. So first thing is, check around you. If it's safe to work where you are, great. If it's not, move the child carefully to an area where there is no potential further danger, and then begin to do the assessment, and we can then start the CPR as required. So we have an unconscious person, or we think they're unconscious, but we don't know. So how do we assess, are they or are they not conscious? And if they are unconscious, what degree of unconsciousness do they have? And there's a simple scale called the AVPU scale, which is alert, voice, pain, unresponsive. So what is this in simple terms? Well, as we approach the casualty, we can speak to them. Hello, are you all right? Have you got a problem? If the casualty is awake, they'll respond, they'll talk with you. Now, it might well be that they have got an injury, but at least if they can respond and talk to you, several things. One, it shows that their airway is clear and they are breathing. It also means that there's sufficient oxygen going around the system that the brain can take your question in, process your question, and then respond with an answer. Now, that answer, if it's a clear answer, tells you that things are okay. If the answer is just jumbled rubbish, ask another question, another simple question, and wait for the answer. And if the answer again is jumbled, that would tell you that potentially there's been a problem. The guy might have, or the girl might have actually had some kind of head trauma, and they're a bit fuzzy at the moment. So we would monitor them. Before an ambulance, we would monitor them and just keep them comfortable. The next level is called voice. So this is the first state of semi-consciousness, shall we call it, whereby when you speak of an individual who's lying on the ground, they don't articulate any answer to you. They might groan, they might open their eyes, or they might twitch a little bit, or they might move a hand. So there is a level of consciousness there that they can respond to the stimulus but there's an injury level or an unconscious level there that doesn't allow them to give a full response. So again, we're going to look after them. We will check them over as long as they're breathing. And again, we'll check the breathing, which we'll talk about very, very shortly. If they're breathing normally, we'll put them into the recovery position. We'll stay with them and we'll phone for medical help. The third level we call the pain response. Now, if the person doesn't respond to either the alert response or the voice response, we can try and stimulate a response by subjecting the individual on the ground to a small amount of pain. Now, this pain won't hurt them, it's a discomfort. And the general ways we do this is we will do an ear pinch on the earlobe, firstly. Secondly, we might want to use our knuckle. And then what we will do, we will rub the knuckle between the top of the bridge of the nose and the eyes, which is quite discomforting. The idea being is we are trying to elicit some kind of response from them. It'll not be an answer. It might be a wince or a twitch, which shows us that we've got some kind of neural activity there. But again, there is a problem. And this will need to be dealt with at a medical level. But again, we will look after them. We will keep them comfortable. And we will monitor their breathing until that medical help arrives. And then the last level is called the unresponsive level. And at this point, no matter what we say or what we do to inflict a stimulus of pain, there is nothing occurring with that individual. As such, we understand that that person is likely in a highly unresponsive state. They are deeply unconscious, and it may well be that their airway is compromised and they are not breathing and the heart may well have stopped. So when we first find an unconscious person, we don't just jump in and do CPR. We assess the level of unconscious first, and mainly around the pain to the unresponsive area is those areas where we may need to intervene with some form of rescue breaths and chest compressions. So if we're at the point where we've identified that the person we don't think is breathing, how do we know that they're not breathing? Well, we've got to do something. We can't just assume that they're not breathing. What we will tend to do, we will put two hands on the forehead. And first thing we do is we just, because of the roll of the head, there's a general sort of roll on the back of your head. As you tilt the head back, it automatically just rolls backwards. And you just maintain the two fingers on the forehead. What that does, it opens up the airway, because when one lies flat, the head drops. And as it drops, the trachea gets constricted just by the natural bend of the head. So we open the head up by rolling it back, which opens up the airway. Then with the other hand, we just put two fingers, or you can go either side of the chin, and just gently just open the mouth. Now, before we go to the next step, you might actually open the mouth and see a blockage in the airway. If that were the case, if it's visible and it's within finger pinching reach, you can try and do a finger sweep and you can remove that object from the mouth. What I would advise, if you open the mouth and look in and there's something deep down at the back of behind the tonsils towards the back of the throat, don't attempt to remove it, because there's a high probability you'll end up pushing it further down the airway, which will make it harder for the medical team on arrival to retract it. So we roll the head back, we open the mouth up by drawing the chin down. What we're going to do then is we're going to do three things. And we're going to do these things all at once. We're going to do a look, a listen, and a feel. So all you're going to do, there's my casualty, there's the mouth. I want to just take my head down. I want to put my ear towards the mouth. And I'm going to do three things. My eyes are looking down the line of the chest. So I'm looking to see if any movement on the chest occurs. Is the chest moving up and down? Yes or no? Depending on clothing and the level of breathing, it may not be obvious if they are breathing. However, with your ear, you're doing two further things. First of all, you're listening. Can you hear any air coming out of that individual's mouth? It might be very shallow, but there will be a sound there, or there should be a sound there, even on a shallow breath. But if you can't hear a sound, the ear is covered in tiny, tiny micro hairs, which are very, very sensitive to airflow. So even if you can't hear or see movement, the hairs will detect very, very finite breath movement. So if there is finite movement on the hairs on your ear, that would indicate there is at least some form of breathing taking place. We monitor. Most likely, you'll either feel and see it, or there'll be nothing at all. And at this point where there's nothing, this is where we have to look about doing or think about doing some kind of rescue breaths and chest compressions, the CPR, the cardiopulmonary resuscitation. So what is CPR? How does it work? What's the sequence? Well, the first thing we do has changed. Many years ago, it was 2 rescue breaths. It's not now. The first thing now is to start off with chest compressions. So what we will do, we will take one hand, and with a fairly straight arm, we will put that hand on the casualty's chest in the center, just below the nipple line. And then with the other hand, we will interlock the fingers, and on the top hand, we turn the fingers under, and then we keep the hands like so, and we place them on the chest. You'll want the arms fairly straight, and as you kneel over the casualty, you want to kneel quite high so that your arms are in a straight position, almost perpendicular to the casualty's chest. Now, we'll look around children aged 9 and above to start with. So for any child like that, what you will do, you will, using your body weight, you will push the chest rib cage down about 2 inches. You will feel resistance, and there will become a natural stopping point about 2 inches. You will push down 2 inches, and then you don't take your hands off. You'll just let the chest recoil back up again, and then you will go back down again. And you will do that 30 times at a rate of around 2 per second. After 30 chest compressions, what we would then do is we would then go to do the rescue breaths, which is 2 rescue breaths. And to do the rescue breaths, I'll take you back to what we did a bit earlier. You will tilt the head back, and you will tilt the head back this time, not by putting your fingers on the forehead. You will pinch the child's nose, tilt the head back, and then with your other hand, you will open the mouth as such. You will then take a normal breath. We're not taking monster breaths here. You'll take a normal breath. You will seal your mouth over the casualty's mouth, and you will blow that air into that casualty's mouth. Now, that doesn't mean it's worked. What we got to do after the blow, we just release our seal off their mouth momentarily, and in doing so, we look down the line of the chest again. And what we should see, hopefully, is the chest rise and then begin to fall. Now, if you can see the chest rise, doesn't need to be a huge amount, but a rise and then a fall, that would indicate that's been a successful rescue breath. You then, 1 second later, you do the second breath, watch it rise, watch it fall, and then you'll go back and redo 30 compressions. And then you'll repeat that process again and again and again. If there's 2 of you, one can do chest compressions, one can do rescue breaths. And then you can swap over, because doing the chest compressions can become quite exhausting. If, however, you do the rescue breaths and there's no rise, don't persist in, I've got to get 2 rescue breaths in. You've done your 2 attempts, they've either worked or they haven't worked, then go back and do your 30 compressions. Then try your rescue breaths again. And again, if they work, great. If they don't work, go back to your compressions. We don't fixate on getting the breaths in before we go back to the compressions. And if the compressions are working, or you're comfortable with the compressions and you're not comfortable doing the rescue breaths, you do not do the rescue breaths. The compressions is sufficient. If we have a child in the age range of 1, 2-ish to 9, 10-ish. It's not prescriptive as such. We do the same procedures, but rather than doing 2 hands, we just do 1 hand. And again, we still go to around the same depth, 1 to 1.5 to 2 inches, but we just use 1 hand. The reason being is the torso is not as well formed. It's a little bit more malleable, which is good in a sense. And obviously, if you put 2 hands on, you are more likely to damage the ribs and the diaphragm and obviously the underlying organs. So we use 1 hand. And then for a baby or an under 1-year-old, we would just use 2 fingers. And for the 2 fingers, it's the same location, it's the same frequency, 30 compressions, but we only go in about 1 inch. That's all we would do, is about 1 inch. And then for the breathing for a baby, this is the only thing that is slightly different, is we don't take a normal breath. What we would do for a baby or an under 1-year-old, again, we still tilt the head back, but this time we just tilt the head back. We seal our entire mouth over both the infant's nose and mouth, because it's a very, very small area. And this time we don't take a normal breath. What we would do, we would puff our cheeks out, check for the rise and the fall, and then again, just fill the cheeks with air. And the air in the cheek void is sufficient to inflate an infant's lungs, because they are very, very small. So that's the only slight difference between an infant and an adult. So we have to be very careful of that one. And again, we keep this process up until medical help arrives. And I think I've already covered this slide already. Once we have the child breathing again, if they become self-sustaining again before medical events arrive, we will stop all CPR. We will place that person in a recovery position, and then we will monitor them until such time as the ambulance, the paramedic, the nurse, or the doctor arrives on the scene. It's a very intense process. I'm not going to deny that. It's a very intense process. It's quite traumatic, but if you understand how it works, it is actually a very simple process. And obviously, as I keep saying, the sooner you can initiate that process, the higher the survival rates are for that child or adult. Doesn't make a difference. As a general rule of thumb, for every minute of delay in commencing CPR, the survival rate of that individual drops by around 5%. So as we can see, if the school nurse or doctor is 2 or 3 minutes away, or you're on a school trip, it could well be that they aren't available or they are delayed somewhere else. If it's 2 or 3 minutes, them 2 or 3 minutes can make a huge difference to the oxygenation of the brain recovery, organ recovery, and then the full recovery of that child without any long-lasting detrimental effects to their ongoing health through their childhood into adulthood. And at this point, what I'll do, this is kind of coming toward the end of this sort of webinar session. I'll just quickly show you a video which kind of explains the different elements of CPR for children and also for infants. And then we'll do a quick summary on what we call recovery position, and then we'll look at some questions.
If a child or baby is unresponsive and not breathing normally, then you'll need to give them cardiopulmonary resuscitation or CPR. CPR is a combination of chest compressions and rescue breaths, which you'll need to do if their heart has stopped beating. By doing rescue breaths, you're acting as their lungs by helping to top up the oxygen. And by doing chest compressions, you're acting as their heart by keeping the blood pumping around their body. Before you start CPR, ask someone to call the emergency services if this hasn't been done already. If you're on your own and the emergency services haven't been called yet, you need to do CPR for 1 minute before you call for help. It's really important that you start CPR immediately. And if the child is over 1 year old and there's a chance that there's an automated external defibrillator or AED at the location and there's someone who can help you, tell them to get the AED quickly.
To give CPR to a child or baby, this is what to do. Lay them down on their back on a firm surface. Make sure their airway is open by putting one of your hands on their forehead and gently tipping their head back using 2 fingers placed under their chin. Give them 5 rescue breaths. To give a rescue breath, this is what to do. Take a breath and, if it's a baby, place your lips around their mouth and nose. For a child, pinch their nose firmly closed and seal your lips around their mouth. Blow gently and steadily into their mouth for 1 second, watching for their chest to rise. Keeping their head tilted and their chin lifted, take your mouth away and watch for their chest to fall as the air comes out. If their chest rises and falls, you have successfully given a single rescue breath. Repeat 4 more times. If their chest doesn't rise, try adjusting the position of their head and try again. You now need to give them 30 chest compressions. To give chest compressions, this is what to do. Lean over them with your arms straight. For a baby, place 2 fingertips on their chest, or for a child, place the heel of one of your hands in the center of their chest, generally level with their nipples. For a large child, you may need to use both hands with your fingers interlocked together. Try to keep your hands or fingertips away from their rib cage, so you won't be pressing down on their ribs. Push firmly in the middle of their chest, about 1/3 of its depth. Release the pressure without removing your hands or fingertips from their chest. Allow their chest to come back up fully. This is 1 compression, before giving the next compression. Compress their chest 30 times at a rate of about twice per second. This is quite fast. It's roughly the speed of the Bee Gees song, Staying Alive. Now give 2 more rescue breaths.
Carry on giving 30 chest compressions, followed by 2 rescue breaths until help arrives. If another first aider arrives, you can switch positions every 2 minutes while waiting for emergency help. If it's really clear that the child or baby is breathing normally on their own, for example, if they start coughing, making a sound or moving, stop CPR and put them in the appropriate recovery position, keeping their head tilted back. It's important to keep monitoring them. If they stop breathing or become unresponsive or unconscious again, you'll need to restart CPR. Stay with them. Keep talking to them to reassure them. Even if they're too young to understand you, the sound of your voice will be soothing and reassuring for them. However, unless it's really obvious that they're breathing on their own, you should continue full CPR until the emergency services arrive to take over, or until someone brings an AED and it prompts you to stop.
So I hope that video just helped to clarify and visualize the process for a child and an infant. Although it's a similar process, there are those nuanced differences, and we must be very mindful of those with the child that we have in our care. The last thing I want to talk about is after we've got the person breathing again, or obviously if they've been choking and they're breathing again, but they are still in a semi-conscious state, or this may still be unconscious but breathing, it doesn't make a difference. We need to make sure that until help arrives, that individual is kept as comfortable as possible and the airway kept as open as possible. And we call this the recovery position. Now, there's a big list of instructions. I'm not going to go through a list of instructions, but I want you to visualize you're kneeling on the floor and you've got the casualty in front of you, lying, head to the left, feet to your right-hand side. And what you're going to do is a series of simple moves, and they're quite simply as follows. First of all, the arm that's furthest away from you, you will lift it up, as you can see in this picture, and you will put that back of that hand under the cheek of the casualty nearest to you. The other hand, you're going to tuck that hand right into that individual's side. So it's right in. And what we normally do is we try to lift the trousers or the skirt, and we try to tuck the hand so it's just under the thigh and the buttock region, and then rest them back. So the hand's kind of trapped under the thigh and the buttock of the leg nearest to you. Then, with the leg furthest away from you, you will bring that leg over the leg that's nearest to you, and you will angle it at around 70 degrees. So at the moment, you've got the person kind of in a twisted position. The furthest arm away from you is up and over the shoulder, and the back of that hand is resting on their cheek. The hand nearest you is under the thigh, and the leg that was furthest from you, you've dragged that leg over the leg nearest to you, and you create a bit of an angle. And the leg nearest to you should be nice and straight. This picture doesn't quite do it correct. What you would then do is you would take one hand and you would place it behind the furthest away shoulder, and the other hand, you will grab the top of the thigh that you've just rolled across, and then you will pull that individual over towards you. And in doing so, what happens is the head flops forward and it rests on that hand. With the elbow out, they can't roll too far forward. The back leg, you just kick it out a little bit, and then it creates a stable platform where they can't roll forward and they can't roll backwards. And then the last thing you'll do is you will tilt that head that's lying down just up slightly. The idea being is it keeps the airway open. So if they were to, quite often after unconscious, people will vomit. So if they were to vomit, the airway is clear. So the vomit will clear the airway and it won't cause a secondary obstruction. Secondly, with the person lying like that, it is also very easy to put your ear back down and monitor the breathing. And we will just keep monitoring the breathing in that position until help arrives. The only thing that could go wrong is they could relapse into non-breathing again, in which case you quickly reset them, push them back onto the back, and you would then once again recommence the CPR process. And we would oscillate between that until help arrives or the individual fully recovers. Now, even if they fully recover, it is still recommended that we keep them where they are until the medical experts can arrive at the scene and they can do a full checkup and either give them a clean bill of health that they can go, or more likely they will take them in the ambulance to the hospital for a full medical examination, any further treatments before they were then discharged. So, like I says, I just paraphrased what's in them two slides there as to get into recovery position. And again, these kind of things, although we're talking about them now, they will be fully explained and demonstrated and practiced in a full first aid course. So I would like to just wrap up that element of what I deem to be the critical parts of first aid that really everybody needs to know and be able to display, because of that 1 in 1,000 chance it could occur to you. I really do hope that it never ever does, but I also think it's better to be prepared. And I'm sure a lot of you have experience and have done training in first aid. I hope you understand it's a 3-year recertification process. I would love to be able to share more with you, and I will in the future. But I just thought, as an opening presentation, to safeguard a child's safety and not feel as though we have a nurse on site or a doctor on site. Yes, it's comforting to know and it's assuring, but in certain situations, those minutes are when it's on you. And those are the minutes that make a huge difference to that individual. So I'd like to thank you for your time. I hope you've learned something. I apologise if there's questions. The way my system's set up, I can't see any chat board. So I'm not sure if Yusuf or Arouge or Asif from IQE, if there's any questions that are being asked, if you wish to communicate them across now, and I'll try and answer them as best I can. If I can't answer them, I'm happy to take them questions on board and build a response through IQA that can then be shared back out to the community. That's not a problem. But thank you for your time this evening. I do appreciate it.
Thank you, Dr. Lindsay. That was lovely, very insightful once again. And a lot of people have joined us over here. Thank you for being here. I hope it turned out to be something very insightful for you guys as well. And if there's anything at all that you would like to ask Dr. Lindsay, he's here right now. We can have a small Q&A session if there's anything at all. Otherwise, we can conclude things over here. Is everyone all right with that? Let me know. If anyone has a question, they can raise their hands, or even in the chat box, you can leave a question. Also, the other thing was that within the chat box, I am basically posting a book, an ebook in which you can also avail a 100% discount. You just have to enter the IQE code over here. It goes by the name of IQE 100. That's the discount code. And here's the link. I've shared it with you all for your reference in case you want to access that. So usually the book is around 100. The course is around 100, 102 dirhams to be precise. But this is, if you use our code, you'll get a good discount over here. So you can access this. Does anyone have any question? Jovlin is over here asking if can you please share the PPT or the video, doctor? So this is, yeah.
Sorry. So just on that note, then, so as you've just mentioned, Asili, is that as has just been mentioned, we are offering everybody who attends this webinar this evening this course through our Transform Training Academy for free. So what I would suggest you do is, if you want to look at this, is take the code that's been placed in the chat box, come along to our website, and for free of charge, you just insert that code log into the website and put that code in, and you will have access not just to those elements, but to the entire first aid program. Now, and that will cover things like cuts, scalds, bruises, insect bites, just to name a few, broken bones. So you will get a much more rounded overview of first aid for children or in the workplace in general, and it will cover what I've gone through tonight, as well as many other topics.
One more question that people are having over here is about the certificates. Yes, you can apply for that. But what you have to do is that for that, you'll have to contact us. I'll just give us your email again in the chat box. So in case you are looking for a certificate, you can just mail us on this email. It's been sent on the chat for everyone. Just look into it, everyone. So it's studentservices@iqeacademy.com. Again, I'm repeating, studentservices@iqeacademy.com. It's there in the email for anyone who wants the certificate. Contact us and we will let you know about the formalities, what needs to be done next. And
just on that note, on the certificates, I just need to reaffirm that what we've done this evening is not an accredited first aid training course. It's a flavour and awareness of critical elements of first aid. So you can get an attendance certificate for what we've done this evening, but it would not give you at this stage a legislative qualification in first aid. That will have to be done through the product that we're offering for free as an introductory, and then a further course which is called First Aid in the Workplace. So I just need to make that very much clear, that don't feel like anybody attending the night after sitting listening to me for an hour and a quarter that they are now a qualified first aider. I've got to be very careful, even from the UAE legislation, that is not the case.
One more thing that I would like to add over here, thank you, Dr. Lindsay, is that you can also, keep a check on the upcoming webinars, whether it's first aid, once again, any other webinar that's coming up. You can always, follow us on Instagram. I'm sharing the link for you all so that you can keep a check. So here's the link. Give us a follow on our Instagram page as well. and you'll get to know about every recent update regarding any CPD, any webinar, any courses that we have to offer that's going to benefit you in the long run. All right, so anything else, Dr. Lindsay, that you would like to add? And one more thing, Dr. Lindsay, like if there's anything that you would like to know about Transform, anything else that you would like to, if you would like to get in touch with Dr. Lindsay, anyone else from the team of Transform, you can again email us at studentservices@iqeacademy.com, and we will basically inform them and we will get in touch. So that's how. And if there's anything related to first aid, if you want to ask anything related to first aid, whereas if you want to inquire about any certain courses related to early years, about teacher training, etc., then contact us directly. Again, IQE Academy. For both these issues, for both these concerns, you can contact us at studentservices@iqeacademy.com. All right, Dr. Lindsay, I think we're good to go. Anything else that's remaining? Would you like to further add anything?
No, I would just like to thank everybody for their participation this evening. I really do appreciate it. I hope we've all taken something away from this, qualified or not, as to what our roles are, which we may not understand. And I would finally just like to thank IQE for hosting this webinar and giving us at Transform the opportunity to work with them to spread some education in the world of health and safety. And hopefully, you know, as already been mentioned, watch this space. There is more to come. So thank you very much.
All right. Thank you once again, Dr. Lindsay, and thank you to the rest for joining. There are plenty of emails that are coming in. For those who are sending in their emails, I'm sharing our email once again for your reference. Like if you are in need of a certificate or anything else regarding Transform or IQE, I'm sharing the email so that you can basically mail us there directly. So here it is. Just give me a sec. Just give me 1 second. So here's the email. Yes, so here's the email for everyone. If anyone wants to communicate anything regarding first aid, or like I said, the courses that we have to offer or the certificate, contact us on this email. Thank you for your time, guys. Thank you, Dr. Lindsay, once again. It was extremely insightful. We loved everything about it. And hopefully we will be seeing you soon. And as for the rest of the learners, I hope it was insightful for you too. So we'll see you soon. Until then, do take care of yourselves. Thank you once again, guys. Bye-bye.
Thank you very much and keep safe. Thank you.